Uh, a very good morning. So I'm very pleased to be here today. So this is our very first, conference AAPONCON, and I'm very happy to be the first lecture to start with. Very important topic that we are dealing with: chronic hepatitis B and C. So is it relevant? Yes, it is. And how relevant? What do we need to do? This is a very long and vast topic to begin with, but I'll try to be as succinct and as to the point as possible, because we need to understand what we need to do with our patients who are suffering from chronic hepatitis. So when we talk about hepatitis B, around 30% nearly in some studies have shown past or current serological evidence of infection. And since 1981, we have a safe and effective vaccine. Now the important thing with hepatitis B is the disease itself, the virus itself, is not cytopathic. So the tissue injury, the hepatitis that we get, is actually because of the interplay of the virus with the host immunity. So if the host immunity is aggressive, actually the disease is more prominent and the patient has more of a problem. And if the host disease, if the immunity is lower, then actually the disease is more indolent, but then the viremia is more. So it is this complex interplay between the viremia and the host immunity which is actually the cause of hepatitis B symptoms and hepatitis B problems. Importantly, if you understand, 40% of men and 15% of women will die of liver cirrhosis or hepatocellular carcinoma, especially if this is perinatally acquired, because then they have so many more years to go through it. Now if you look at the past of hepatitis B, so today's we have the past, present and future. So since 10 millennia there have been some evidences which have been found paleontologically of hepatitis B infection. And the first record was of an epidemic caused by hepatitis B virus. So it is very interesting. In a shipyard there was an outbreak of smallpox and they were vaccinated to prevent this. They were vaccinated with lymph from others and they found to have jaundice after that. So this hepatitis B infection was then found. And of course, the largest ever record of infection was by soldiers during World War II, by the American soldiers. And of course, it is the Australia antigen, because in Australia, Aborigines, it was first found and detected. The hepatitis B virus was isolated. Now, if you look at the scape all over the world, this is, yeah. So I think the pointer is not working well. Yeah, just give me a minute. I'll use the on-screen pointer. So if you look at this, India is somewhere in the middle, so there's a moderate rate of infection, and genotype D is the most common. Now unlike hepatitis C, the genotypes are not very important with hepatitis B. Now what is important is the infection, the chronic HBV. When you say chronic HBV, at least 6 months or more hepatitis B surface antigenemia should be positive, and the risk of, yeah, it's okay, fine, I'm using the on-screen pointer. The risk of developing chronic HBV infection exposure after acute exposure, it's very important that in newborn, the risk of chronicity is much more. Almost 90% will be chronic, and in adults, only 5 to 10% will be chronic. So the timeline when the infection occurs is also as important for development of the infection. And even with active and passive immunization, almost 5 to 10% babies will acquire infection at birth, and around 20% of people with chronic hepatitis go on to have cirrhosis. So that is a problem. So this is a very important thing, because problem with the hepatitis B virus is the virus forms a covalently closed circular DNA, the CCC DNA, and this is in the nucleus. This integrates into the host DNA. So the problem with this is whenever we were trying to eradicate the virus, it is inside the host DNA. So getting rid of it is the most important part of it. And unfortunately, till now, the current therapies, very few are there which actually can eradicate the virus, and especially the interferons which are used, but the rate is extremely low. So we don't have a cure yet which can completely cure the virus. And that is where the problem lies, because we are treating the patient definitely, but we're not curing the patient completely. So the CRISPR technology, gene technology, is now, I think, the advent where we can use this. So I'll be touching it upon my last slide, but this is how we are doing. So after viral entry to integration and then again formation of the antigens, that is the most important part. We need to understand where we can hit the virus hard. Now this is a very important slide. If you look at this, this is the first one, is on if the patient gets an acute infection and if the patient's infection resolves. So you have the hepatitis B surface antigen which is there. Once it resolves, you form the antibody, the anti-HBs. And you see the DNA is there initially, the DNA is negative later on, and the patient has HBe antigen seroconversion. The antibody, the core antibody also can be present initially, but then from IgM it turns to IgG. The problem is when there's a chronic infection, the HBsAg persists, the DNA persists, and there are flares in the middle, and these peaks are basically flares where there can be injury. So any flare means liver enzyme is rising, means there is injury to the liver tissue, and of course this can cause damage to the liver tissue. This goes on to cirrhosis, and ultimately liver cancer is the last point. So when the patient comes to you, we ask, how do we evaluate these patients? So this is the most important thing. Simple history of vaccination, family history of HCC is very important. Remember, the family history of HCC has a bearing on the patient's treatment, because if there is a family history of HCC, you have to treat the patient regardless, because the virus is inside the liver cell and the patient can get HCC. So that is very important, this history. Routine blood work includes this complete blood counts, the LFTs, of course rule out other causes of liver disease, HIV, HCV must be done. AFP, alpha fetoprotein, is very important to look for periodically. The important two tests which we do is HBe antigen and the HBV DNA, quantitative, not the qualitative. So these two things are very important. And of course fibroscan or any elastography to look at the fibrosis, invasively, non-invasively, anything, and the USG. These are at least the most basic tests we should do for all our patients who come with hepatitis B. Now, of course, liver biopsy is indicated in some cases, and when we talk about the treatment, I'll discuss that, especially the patients who are having fluctuating liver enzymes. Patients who are more than 40 years with cirrhosis or with history of HCC must undergo AFP screening. Now it has become universal. Importantly, what is the goal of therapy? So whenever we talk about goal of therapy, can we eradicate the virus? At present, very unlikely. So the goal of therapy is HBV suppression, and the patient's inflammation, basically the liver enzymes and inflammation, should subside, and the liver disease should not progress. This is the current goal of therapy with HBV. We cannot treat the virus completely and say the patient will be cured. So we have to tell our patients on the first instance. And we need to assess the patient through all parameters. That is why HBV is complicated, because we just can't look at the virus and say you need treatment. The virus can be 10 millions of levels, but it has to be virological, the serological, biochemical, and of course all the histological diagnosis should correlate with treatment. Now if you look at the serology, a lot of markers are there which are done by so many labs, and we ask which serology to send, what is the implication. So hepatitis B surface antigen HBsAg, anti-HBs, anti-HBe, HBeAg, and the total core antibody, which is IgM and IgG, are the main markers we send. So importantly, if there's past exposure or immunity, you'll find the anti-HBs is positive and the anti-HBc is positive. Total core will be positive. The patient will have IgG levels basically. So this means that the patient is having past exposure, past immunity. Patient who is immunized against the surface antigen only. So only anti-HBs will be positive, no core antibody will be there, right? Chronic Hep B, HBsAg positive. DNA is very importantly positive. It can be in the mild levels, high levels, depending on that. And the liver enzymes are elevated. So chronic hepatitis means enzyme levels will be high. And of course HBe antigen, we'll discuss that, but can be positive, negative, all. So it's very importantly the enzyme levels are elevated, which is a marker of chronic hepatitis B. There are certain pre-core mutants. So mutants which do not have HBe antigen, but they are still actually quite infective, and the patient is actually having active disease. So again, liver enzymes are high. So importantly, for patients of hepatitis B, the liver enzyme will tell us whether the patient is actually having active disease at the moment. The infection can be there, but whether we need to treat the patient, the liver enzyme is a very important marker for us to understand this. Now what about the vaccine? Now there are combination vaccines now available, especially in the US. Of course in India, we are still very limited in our vaccination status. So combination vaccine against hepatitis A and B together are available. Importantly, for all the healthcare practitioners, the anti-HBs titer should be more than 10, and it is achieved in 95% immunocompetent. So whenever we check for immunocompetency, and suppose you have a prick, and we'll discuss that, it is very important to realize whether the anti-HBs titer is more than 10 or not. If it's not, then you get a booster dose done. Now protection has been estimated for a single dose for up to 15 years and possibly lifelong, because there are memory cells formed. So even if the titer falls, most studies have shown that there is protection, but still according to guidelines you must take a booster if your titer is low. And of course there are certain escape mutants, which is the vaccine escape mutants. So unfortunately some data is there where in patients who are vaccinated, some escape mutants, actually surface antigen escape mutants are there, which can actually replicate. These are not protected by the vaccine. And of course, see, after 1 month of the scheduled completion, 90% are protected. So patients ask me, if I'm getting married, when can I have relations with my wife, and so on and so forth. So you tell them after you complete the vaccination schedule, 1 month is a time when you need to be very protected. That's very important. Now if you look at the vaccination schedule for all ages, we have the 3-dose vaccine, of course, for adults. This is common for both India as well as the US. You have for the adults it is 0, 1 and 6 months, and of course for infants at birth then the first month, then the 6 months. Again, they can be given, but of course 0, 16, 26. Again, the 4-dose combination series available for infants: 0, 6 weeks, 10 weeks, and 14 weeks. Now, this is of course a combination vaccine where there is Hep B and you have the other vaccine available as well. Now, there is an accelerated vaccination schedule. So, for example, if a patient is having a family member who is hepatitis B positive, they should go in for the accelerated schedule, not the normal schedule. Because if you are giving them doses at 0, 1 and 2 months first. So, giving at 2 months means there is a higher rate of protection early on. And so these patients are protected. Still, these guidelines are not for the regular people, but for the patients who are contacts, healthcare workers who have been exposed or who are near patients who are exposed, they should be given the accelerated vaccination schedule. Of course, in India, we don't have a vaccine which is called Heplisav. Heplisav V is a new vaccine with a new adjuvant. Only 2 doses are required 1 month apart. So it's available in the US, not yet in the country, and it's been available in the US for the past 3-4 years now. And of course, we have the Hep B combined vaccine available also. So we need better vaccines here, and it's very important that we can vaccinate. Now, what about people who are pricked with a patient who has hepatitis B? And that is a very important patients who come to me, doctors who come to me and ask me, what do we do now? So look at the red blocks, that is the most important find. So if the patient is, the doctor is or the healthcare worker is unvaccinated or non-immune, 2 things need to be done. The immunoglobulin must be given and the vaccination series must be initiated immediately, different arms, and that is very important. Now, in most cases, the source is not available, is not known. You must treat the patient as a source positive. That is the most important part. Don't treat as a source negative. You don't know the patient is gone, the patient is not getting tested themselves. You treat as source positive. If the patient is actually found to be source negative, you can just initiate the vaccine series. That's enough. Now, the thing is, it is about the responders. So, in our country, very few people actually get their anti-HBs levels done. So, in most scenarios, we don't know our own status. Whether we anti-HBs titer is high, titer is low, we don't know how protected we are. And in fact, a lot of people also forget whether they completed the vaccination schedule or not. So this is something which we must important. So people who are non-responders, who are anti-HB titer is low, you know it, you can be treated as unvaccinated. But people who are vaccinated with the complete series, but you don't know the antibody response, very important. You've taken the vaccine maybe 20 years back, you don't know your anti-HBs level, then you must take the single dose of vaccine immediately. That is very important on the first day, in the first hour itself, and you send the titer. The titer level will take 1 day to come. So you send the titer level. If the titer comes below 10, you get yourself complete vaccination done. You've already taken the first dose. If the titer comes more than 10, then you can just relax. You've taken 1 booster, that's good enough. And people who are undergoing the vaccine, they've taken half of the vaccine. It is very important you take an immunoglobulin level, immunoglobulin shot, and you complete the 3 doses of vaccine. So this is the most important part, and most of people fall in this category. We have taken a vaccine, but we're not sure what our antibody level is. So take the booster and then send the anti-HBs level. Don't wait for the anti-HBs level. So here are the drugs that we have used, so many drugs all over the years, starting from interferon, I think the prolific antiviral which we have used. And interferon 1992 was the first use of interferon in hepatitis B. And we have moved all the way down. Now we are using tenofovir alafenamide, I think the universal drug which is being used with least side effects and the most efficacy for hepatitis B. So since 1992 to 2016, it's been a long path. And if you look at the drugs, so PEG interferon alpha 2A being used 180 microgram weekly. The problem is you need to check for autoimmune diseases, you need to check for flu-like symptoms, and of course the counts drop. So I remember in our department we used to check the CBC every week, and of course the doses has to be modified depending on the response and the counts. Now let's look at the other drugs. The most important is entecavir, still in use, 0.5 or 1 milligram daily. Can be used for people who are more than 2 years of age. So children also more than 2 years of age, you can use it. And of course, the problem is if lamb exposed, now we don't have lamb exposed people now at present. So for them, you use 1 milligram per daily. And tenofovir earlier was 300 milligrams TDF. Of course, could be used more than 12 years of age. The problem was bone disease. The problem was nephropathy. So now we have the congener, the tenofovir alafenamide. The TAF is the new prodrug which has lesser plasma levels. So 25 milligrams is enough, but can be used for more than 6 years of age, and the side effects of bone disease, kidney disease are no longer so relevant. But is interferon gone? I mean, we've used interferon for so many years now, so it's very difficult to obtain interferon as well. Very few companies are manufacturing interferon. The thing is still in the ring because it has both antiviral immunomodulatory activity. So it's activating the virus, working on the virus on both fronts. And though there are, like I mentioned, side effects, It is contraindicated for those with liver failure and cirrhosis. And of course, we have used PEG interferon. Now, the thing is, the benefit of PEG interferon is the HbSAg seroconversion rate and the HbEAg seroconversion rate is very high compared to the oral therapy. So, around 30% almost for HbEAg seroconversion, where the E antigen is lost, and the surface antigen, which is actually the cure, 3 to 7%. So, almost 5% we can actually say that there is a cure. And of course, how do we select these patients? That is upon me, but we select the patient depending on the high ALT levels. That means the immunity level is good, they have good immunomodulatory response, the DNA levels are lower, and their viral genotype A, especially female patients, have been found to respond very well to interferon therapy. Now, if you look at the oral meds, so nucleoside analogs, they inhibit the reverse transcriptase, but importantly, they just suppress the reverse transcriptase. So, HbEAg becomes undetectable in 50-60% of patients. ALT normalizes in most. HbEAg seroconverts, but HbSAg loss, which is the cure. See, surface antigen loss means we are near a semblance of cure. This happens only in 0 to 3% of patients in 1 year. So this, seroconversion rate is so poor, that's why the patients need to be nearly on lifelong therapy. Patients cannot stop the therapy, and that is the main problem. So resistance is very low with entecavir and tenofovir, and long-term therapy actually has been found to reverse cirrhosis as well. So it's very important that these patients, even if they are having a fibroscan level of 15, 16, 18, they've been found to drop down with therapy. In fact, I have a patient right now whose level was 25. After 2 years of therapy, the patient is now at 7.5 of fibroscan level. So doing very well and decreases HCC. So how long do we use? So interferon therapy is for 1 year, but oral therapy, now there are different guidelines, different data, and there's all controversial. If HbEAg positive patients, they become HbEAg negative, so the E antigen becomes negative. After 1 year, you can think of stopping the therapy, but remember the relapse is almost 30% or 40%. So we have to be very careful. The patient must be motivated enough to do test levels almost every 3 months. So it's very important, and every monthly LFT is required. Now, people who, in patients in therapy, you see 45% of patients had a relapse. So in most patients, we tell them the therapy, take it for granted that it is lifelong. But yes, you have to be motivated enough to stop if you can stop. So importantly, current therapies only suppress but do not eradicate. You need to treat the ALF, you need to acute liver failure, decompensated cirrhosis, and exacerbation of HBV infection. So you must understand who you are treating. We don't treat all. If you're treating the patient who has just high DNA levels and everything else is normal, then the patient actually it's not working for the patient. The patient is taking the drug, but there's not going to be any change, no response. The patient is not going to have any benefit in the HCC or the other therapies. But yes, certain data is now giving us some clue that we might start therapy for them as well. Remember, a lot of this data is insurance driven. So in the US, they have to pay for every single drug, every single molecule. So they want to pay out, they will think that where should be pay out for them. That's why these guidelines have been made, where therapy is limited to a few, not to all. That is important. Now, importantly, therapy should be given to all cirrhotic patients, regardless, and for patients who are immunosuppressive therapy, and of course, even anti-HB core antigen positive, core antibody positive, who are HbSAg negative, who are going to be on immunosuppression. Because immunosuppression means there is going to be a flare. So this is our guidelines. This is the Asia Pacific guidelines with the INASL, and very complicated usually to discuss and understand. But mainly, if you see, the DNA level more than 20,000 and the ALT level is high. In those patients, if it is sustained high, then you must treat the patient. If it is 1 to 2 again, you can check for fibrosis non-invasively, and it should be done for all. If the patient is having any fibrosis, you should treat the patient. And this inflammation is there. So in most such guidelines, they are mentioning liver biopsy. The problem is motivating a patient and getting the liver biopsy done in our country is extremely difficult, especially in our setting. So the problem with all these guidelines lies in there, that when you treat the patient, so we have a fibroscan, we have elastography, which gives us a good idea about the fibrosis. So for all our patients, do the DNA, do the enzyme, do the fibrosis level. These three, they are correlating. It's the fibrosis is high, the enzyme is high, DNA is high, you treat the patient. The patient who is a DNA, and this is for HbEAg positive patients. So E antigen positive means the replication is quite high. So in these patients, DNA more than 2,000 to 20,000, again, check the enzyme, check the fibrosis. If it is all elevated, you treat the patient. If the DNA is less than 2,000, this is very unlikely the enzyme levels are high because of the virus. So very importantly, if the DNA level is less than 2,000 for HbEAg positive, that means the patient is not having a very high load of the virus. Still, if the enzymes are high, the fibrosis is high, you need to check for other causes, which might be the cause of such enzyme elevations and such fibrosis. But again, even in such patients, if the enzyme levels are significant, fibrosis is there, we treat the patient if required. Now in HBeAg negative, the level is 2000. More or less the guideline remains the same, but mainly 2000 because the replication level is low for E antigen negative patients. And for E antigen positive, the replication is high. So the cutoff is 2000, 20,000. That is the difference. Otherwise, most is similar. The better guidelines which we actually follow therapy is the European guidelines. This is the EASL European guidelines. And of course, here it's very clear cut. Again, they mention see HBeAg positive or negative. It is more than 2000. ALT is more than upper limit. Upper limit is 40 in our country. So our data mentions 40. For them it is 32, but for us it is 40. And any liver of any amount of fibrosis, you treat the patient. So the guideline is very simple for EASL and the European data. They treat most of the patients with this. Compensated cirrhosis, decompensated cirrhosis, treat the patient. Simple. And of course, patients who have high DNA and whose liver enzyme is high, so 20,000, more than 20,000 and high ALT, you treat the patient regardless. And of course, this is now interesting for patients who are more than 30 years of age, who have persistently normal ALT, the DNA level is high, and who have a HBeAg positive, you may treat the patient because they have a high risk of progression to liver cirrhosis and liver cancer because their age group is higher. So this is very interesting, which is there in the EASL guidelines. They are treating more such patients who are positive. And of course, family history of HCC, like I mentioned, or cirrhosis, you must treat the patient. So it's very important. Now what is reactivation of flare? If the DNA is rising more than 100 times from the baseline, or if the patient is, if the ALT is rising more than 5 times, this is called a flare. And of course, in such flares, there is fulminant, can go to fulminant HBV infection. There can be liver damage, and of course, cirrhosis and hepatitis C. We can also have the extrahepatic manifestations, glomerulonephritis and vasculitis, and polyarteritis nodosa, because of the immune response. So whenever we have these patients, and of course, a lot of our patients are on steroids, on other drug therapies, what do we do with these patients? So we determine the risk of reactivation. I will take you to the next slide. HBsAg negative and anti-HBC positive. If it is a low risk of reactivation, I will show the slide of low risk of reactivation, we just monitor. So on therapy you monitor. But if it's a moderate or high risk, again, even HBsAg positive, moderate or high risk, the DNA level is there, then you have to start anti-HBV prophylaxis. And that is the most important part of it. So low risk patients, low risk therapy, you do not have to start therapy. Moderate to high risk of therapy, you must start the therapy for patients who are positive. Now if you look at the risk of reactivation, all prednisone equivalents less than 20 milligrams, azathioprine and congeners 6 mercaptopurine methotrexate, you are low risk of reactivation. So you don't need to put the patient on immunoprophylaxis for HBV, even if they are anti-HBC positive or HBsAg positive. So that is the important thing. Other patients, yes, you must put the patient on prophylaxis. So all cytokine-based therapies, immunomodulators, other high-dose steroids, 20 milligrams and beyond. So all our patients of IBD, we are putting on 40 milligrams of isolone. They have to be on they have to be tested for anti-HBs, anti-HBsC, and they have to be on therapy because otherwise they'll have a flare. And for how long? Usually we say till the immunosuppression persists for at least 6 months to a year. So some guidelines say 6 months, some say 1 year. We can give the patient therapy. Now if you look at the pregnant patient population, now the risk of liver progression, the concern for vertical transmission is there, but we must also weigh in the pregnancy, perinatal side effects of the drugs. Now if you look at it, there have been multiple studies, and the most important studies have shown that when the viremia level is higher, so more than 20,000, or some say more than 22 into 10 to the power 5, then actually is the risk of transmission to the baby. So we look for it in the after the second trimester, so 26 weeks. And when we find it is high, then you can reduce it. Of course, cesarean section has been found to reduce the risk of transmission. So for patients who are actually HBsAg positive, elective seizures can be thought of as a treatment. And of course, babies should receive both HBIg at birth and the vaccine at birth on different parts of the body. Now if you see first visit of pregnancy, if the HBsAg is positive, active disease or cirrhosis, you must consider treatment. If the HBV DNA is taken, should be done then, and again at 26 weeks to 28 weeks. And if the DNA is more than 2 in 10 to the power 5, only then should you consider treatment. And if it's low, don't think of treatment because you are not going to change the patient's prognosis in transmission. So that is a very important part. And of course, therapy can be given up to 3 months post-delivery, and then you can stop. Of course, so entecavir or tenofovir, if anything else is using, shift to tenofovir. It has been found to be the most safest drugs, and the patient can be monitored. Now again, HCC, the most important part of HCC. So 30-50% of patients of HCC associated with HBV occurs in absence of cirrhosis. So even without cirrhosis, the patient should be monitored because these patients can develop HCC without that. So the progression is around 15% chronic hepatitis to cirrhosis, 20% to decompensation, and of course 10% will move on to from compensated cirrhosis to HCC. So it's very important. Every 1 in 10 patient of compensated cirrhosis moves on to have HCC. Older ages, males, cirrhosis, family history of HCC, obesity and diabetes are all risk factors for HCC. If you look at the future, this is the last slide for Hep B. If you look at the future, the correlation has been shown to have with the HbS-Ag concentration and the cccDNA. So HbS-Ag titer is actually partly correlating with that cccDNA in the nucleus. So we possibly might be looking at titers as a better marker in these patients in the long term. This CRISPR technology is actually now what we are looking at for editing the DNA and causing improvement in the patient's therapy. And combination therapies are being thought of. TNF, I mean the interferon plus nucleoside analogs or interferon with CRISPR technology we are thinking of in the future. Now we'll discuss the HCV in short. Of course 1% of the population is infected with HCV, and earlier it was thought of as the non-A, non-B virus. And of course we've all been through that, and the anti-HCV antibodies testifies to infection. Now seroconversion takes around say about 1 month to 2 months, and HCV viremia is detected by RT-PCR. Now if you look at the past, what was happening in cases of the hepatitis, the non-A, non-B hepatitis was first diagnosed, and actually for them interferon was used even prior to diagnosis of HCV. So interferons were being used for these patients who are having transfusion associated NA and B infection. Then we moved on to interferon and ribavirin therapy. We moved on to directly acting antivirals, and of course now 2014 onwards we have excellent therapies for use. And the important difference is HCV has no reservoir inside the body, so it can be cleared off. So we have good therapies to clear off the virus, and of course ribavirin was used, ribavirin has been used with its side effects, but it has got excellent efficacy in initial part. Now we have much better drugs. We had tenofovir and boceprevir, the initial DAs, 75% response rate was there, but now with the pan genotypic regimens, the multiple genotypes, you are having the regimens, almost near 97% cure rate is there with HCV. So nothing to be scared of with HCV now. People who are now aged 60 to 80 are more prone to be having HCV because of the infection transmission rates at the time, and this is what we should test for. In the US and in the West, they are testing everybody. Opt-out is there. In the country, we don't have opt-out therapy, we don't have opt-out options yet. HCV has multiple other problems as well. Hepatotropism causes hepatitis B, hepatitis and cirrhosis, HCC, but it can cause chronic kidney disease, vasculitis, extrahepatic cancer, increased cardiovascular disease and strokes as well, and neurocognitive decline. Now if you look at it, the HCV viremia in this country, almost 0.5% seropositive rate, and testing of all blood donors was made mandatory from 2001. But even then, we are not using the NAT test. So the NAT is one of the actually the most specific and sensitive for this, but of course unfortunately we are still not using it, only 2% till 2017 by using NAT. And a lot of patients actually they miss this. Right now in the country we have 4 drugs available, the SOF, Velpa, Ladipasvir and Daclatasvir, and we look at the NTEP, we had the NTEP program which was there. Even then, with free therapy, 15% of people drop out. With HCV, we have the NVHCP there, Non-National Viral Hepatitis Control Program. We expect a similar number even with free therapy to drop out. So we have the genotypes with hepatitis C virus. The genotypes is important because they have different efficacy with the different drugs. In India, especially in the East, we have genotype 3, which is the most common. And if you look at it, we had the interferon era, and now we have the DAA, the directly acting antiviral era, where we are thinking of elimination. So if you look at the evaluation, we must look at the anti-HCV, that should be positive. The HCV RNA should be done, especially for immunocompromised. Even when anti-HCV is negative, we can do the RNA. And now we don't need genotype because we have pan-genotypic drugs. Regardless of genotype, the drug is working very well.
Dr. Pratik, you have 5 minutes
5
more.
Minutes, yeah. 5 minutes, I need 5 minutes, yeah. So we are using all the serological markers for them as well. Now if you look at the pre-therapy, vaccination should be done for hepatitis A and B, and of course pneumococcal vaccine as well. And the goal of HCV therapy is sustained virological response. You treat the patient, the therapy is done. After 12 weeks, the patient should not have any virus. The HCV RNA should be negative. Important to tell our patients, people who are on anti-hypoglycemic agents, on oral anti-hypoglycemic agents, they can develop hypoglycemia. That is very, very important. Post-therapy, it has been found that the sugar drops. Secondly, the anticoagulation status, it has a drug interaction with warfarin. So it's very important to understand that the patient can have changes in the INR level. So check for it more frequently. And of course, patients who are both positive, HBV, HCV positive, they can be put on HBV therapy as well. And some guidelines mention you just keep monitoring and treat them if the ALT levels rise again. Now the current therapy, this is the baseline therapy we are using for everybody. Sofosbuvir and velpatasvir combination therapy once daily for 12 weeks. And for patients, this is non-cirrhotic patients. For patients who have cirrhosis, the problem is the clearance rates are lower. We are still using for 12 weeks, but for cirrhosis, we should do the genotype levels. If the genotype is 3, in those patients, the clearance rates are much lower. So in those patients, we might use different therapy. Especially for decompensated cirrhosis, we use soft velpa with ribavirin because they don't clear the virus otherwise. For 12 weeks, or if you are not using riba, then you have to use soft velpa for at least 24 weeks. So this modification must be done for cirrhotics, especially decompensated cirrhotics, otherwise they will not respond to therapy and they will relapse. Very important slide for our friends here, the drug interactions. Very importantly, the patient who are on antiarrhythmics, amiodarone, is contraindicated with soft velpa. So the patient's drug therapy must be changed. Carvedilol, the timing must be changed. Diltiazem, the timing must be changed. Atorvastatin, again very importantly, very commonly used. So with soft velpa for 12 weeks, either change the drug or change the timing of the drug. So this is very important. Rosuvastatin as well. And all the anticoagulation as well, like I mentioned, warfarin, when you're using the drug therapy, the drug level will change. So change the timing, check the INR more frequently. And all the anticonvulsants, soft velpa, you see contraindications with phenytoin, primidone, carbamazepine, so we cannot use the drugs. Now what about if you get a prick with a hepatitis C positive patient? What do we do? Now it's very simple. The anti-HCV, baseline anti-HCV is positive and HCV RNA is positive, start therapy. But if the anti-HCV is negative and the source was found to be positive, the patient who was positive, in that cases, you do the NAT, if positive, nucleic acid test for HCV RNA, 3 to 6 weeks after exposure. If the HCV RNA is positive, you treat the patient, treat the doctor. If the HCV RNA is negative, again you must wait for 4 to 6 months, repeat the anti-HCV and HCV RNA. And if it can still be positive, then you treat him. So you have to wait for at least 6 months before you actually confirmed you are not getting a infection from HCV once you're getting a prick. So till that time you cannot be sure and you still need to get monitoring. Now last 2-3 slides. For pregnancy, antiviral therapy is recommended before pregnancy, and importantly there is no current intervention known to reduce the transmission risk. Importantly, tell the patient the high risk of ICP, intrahepatic cholestasis of pregnancy. Liver enzymes may rise, so problems can be there. But currently, DAS is not recommended, though most studies have found to be safe, but still not in the guidelines. So we tell the patient you wait. Once delivery is done, once the lactation is done, then you can proceed with therapy, or you start formula feed and then you give therapy. And you can, a lot of patients actually when they regain the immunity post-delivery, post-pregnancy, actually the immunity clears the virus itself. So a lot of patients have a clearance. So you wait and you check the HCV RNA again after 1 month, the patient may actually cleared. What about children? Of course, DAs have been approved now for children more than 3 years of age. So for children, importantly, at 18 months you test for the anti-HCV, even if they were negative in the initial part, and you check the RNA at 3 years of age. Because before that, the patient will not form the immunity, they will not get the anti-HCV as well, and the RNA also may be very low titers. Now what about vaccination? Why are we not using last 2 slides left? The vaccination, the challenges is the huge genetic diversity. It does not have a proofread mechanism, the RNA-related RNA polymerase. So we are looking at multiple options. Multiple vaccines are in the pipeline. This is the future that we must talk about, and I have the last slide of take-home message after this. Future is HCV patient comes to you, you test for HCV, you give the patient the drug therapy and the patient goes home. So this is what we are looking at in the future, that the patient, one point of contact, the patient comes, tests, treats and goes. And this is what we are looking at. So we need point of care testing and point of care treatment. What the US government is now applying, we need to apply in our program as well. And this will probably cure and eradicate this virus from the country. So to finish off, HBV, hepatitis B, effective vaccine but ineffective cure. So only thing we get is a plus minus scenario, we get a control. So it's very important, tell the patient we cannot cure you but we can control your disease, effective control. HCV, no effective vaccine but effective cure. So possible elimination is there, but the patient must be compliant. So it's very important that you must test for compliance and test SVR12 that the patient is cleared. And for HBV therapy, importantly, not for all, each case is different. Evaluate everything and then treat the patient. We just can't give therapy if the DNA level is high. And universal testing is the need of the hour. Like the Western countries, we must have an opt-out testing guideline. That the patient, everybody who comes to the hospital, ask them, we are going to test you. They say, no, you can write it down. But otherwise, we will not be able to eliminate HCV virus, even with good therapy. Thank you.
Yeah. Dr. Pratik, thanks for a very nice and elaborated description of the two complex diseases in a very short duration in a single platform. Thanks to you. Few questions are allowed from the dais, 2 or 3.
Yes, sir. You can have the
Yes.
mic. Yes.
Yes, sir.
One patient, actually, his hepatitis surface antigen is positive since last 20 years. There is no, the enzymes are not raised throughout we check every year. Initially DNA was positive, but it was in the lower range. And HPC, anti-HPC is still positive. So whether you need, and the patient is healthy, no antiviral therapy was given, no immunosuppression was given. And do you think we should follow up further, or we just now stop following?
Sir, follow-up should be lifelong. Until, there is no guideline on stopping follow-up, because these patients, they have the, like I mentioned, CCC DNA. So even any time of their life, the patient can go into flare. Even if the DNA is undetectable, it doesn't mean that the patient is completely cured. So it's very important that the follow-up should be done. The guideline mentioned LFT should be done at least 3 monthly. Of course, unfortunately, it becomes very difficult, but 3 monthly LFT and at least 6 months to 1 year DNA level should be done. Like I mentioned, if the patient is HBe antigen positive, the cutoff is 20,000.
Yes.
If it is E antigen negative, in most cases we get that, the lower level is 2,000. So if the patient is even below 2,000 and the LFT is normal, you don't need treatment, but you still need follow-up. And if you need also follow-up for the HCC. So we should very important to check for HCC as well. So UAG should be done every 6 monthly to 1 year at least, and AFP level also should be done for the patient.
The wife's surface antigen is positive still throughout the last 20 years.
Yes. So surface antigen negativity is hardly 1 in 10 years time, even on therapy. So without therapy, the negativity rate is very poor. So like I mentioned, the DNA, the problem with the hepatitis B virus is it forms a closed circular DNA, and this integrates into host DNA. So this surface antigen will keep on remaining positive, because the surface antigen, the molecules are formed and they are being released into the body. But I would say, even if if the DNA can be 0, it can be non-detectable, but then still the patient will have positive.
Anti-HCV, surface antigen is still negative.
Absolutely, sir. That can be there. So the patient not forming immunity, na?
Okay.
Patient not forming immunity. So effective, the immunity is ineffective, the patient will not become positive.
This patient is still infective?
So patient is infective, definitely infective.
Thank you.
Yes, sir. Next.
Yes.
Hepatitis is one of the what is called stealth pathogen, like H. pylori, Giardia, Nocardia, Candida, and of course Brucella also. They have their own mechanisms which allow them to persist in the cells, avoiding the immune response of the cells. This is one reason why there is ineffective cure despite treatment. Number one. This is my comment. And the question is, suppose if I have pricked today with HIV, HBs positive patient, when should I test for myself?
Sir, for you, like I mentioned, you must take the vaccine first of all, first dose of the vaccine. You check yourself for anti-HBs level. Same day. Anti-HBs level will take 1 day to come. If you must have, that depends on whether have you taken the vaccine. If you have completed the vaccine, you still take 1 dose of the vaccine and you take anti-HBs level. If the anti-HBs level titer comes tomorrow and is less than 10, then you must complete the vaccination course. You check yourself for surface antigenemia after 6 months. And if your anti-HBs levels titer come more than 10, 1 dose that you took today was enough for you. So you don't have to get yourself vaccinated again. That's it, sir. Yes, sir.
Dr.
Please.
Poddar,
Yes.
there is one patient, we lost his father in hepatocellular carcinoma
Absolutely.
due to hepatitis B. His brother also died due to hepatitis B for some other reason. Now that young patient is having hepatitis B positive from last 2 years. I have given him tenofovir regularly.
Yes.
He is having many times DNA negative, qualitative. But after 6 months again it goes more than 10,000, 20,000. SGOT, SGPT normal. No evidence till now for fibrosis. How to monitor further?
Absolutely.
Because now cost is becoming prohibiting for him.
So I will tell you, sir, and that's the last point was the most important. So there was a study which was done in Maharashtra. They found that even with therapy for HCV, which is streamlined therapy, and for HBV also, only 14 months is the average compliance rate that the patients comply with. So in 90% of people who are having fluctuating DNA levels on therapy, the problem is compliance. They take the drug for 6 months, they drop it for 1 month, then they take it again for 6 months. So they will develop resistance even to tenofovir in such cases. So the problem is the compliance should be ensured first. The patient, if required, should be given. The patient can come to your clinic every month, show you if they can. They should get the drug box along when they say I have got the drug here. So that is what we do in our clinic. We tell them you get the drug box along. You see you have not completed how many. So they keep missing, sir. So in your case, the likely diagnosis is the patient is missing the drugs. Even on therapy, suppose I take it that the patient is compliant. In that scenario, chance of drug resistance is high. Because if DNA level is falling and then going up again, then drug resistance and the patient might require combination therapy. But yes, so combinations are this. So here we evaluate every patient differently, but usually entecavir plus tenofovir combinations are given. Sometimes we can give them interferon also depending on the patient's immune response, genotype. So these patients require very comprehensive evaluation. First is compliance, then you go for a genotyping. You can go for drug resistance testing also in these patients, and then you can decide what therapy to be given. But in 90%, I am pretty sure the patient is having compliance issues.
So I think we have to.
Are the patients who have cirrhosis due to chronic hepatitis B, are they suitable for liver transplant?
So absolutely. So for all patients who have cirrhosis, they are suitable for liver transplant. Now for a question here arises whether we treat them or not we treat them, we should treat them. Treatment should be started because listing of transplant, the patient will have average lifespan around 1.5 to 2 years will take for a transplant to happen. Patient should be started on therapy, listed for transplant, and they should go for liver transplant if indication is there. So we
still with high HBV DNA?
Absolutely, sir. So the patient will die of cirrhosis, not of the HBV. So like I mentioned, the viral level, the DNA level is not important. The importance is the patient's necroinflammatory activity in the liver. So if you're having activity, the disease, you should get a transplant done.
So we are winding up this session. Actually, next question we can discuss on the out of floor. Only one comment from the dais. The problem in hepatitis B is the gray zone, which we call the indeterminates, where is a clear-cut guideline for the inactive carriers and active carriers. But the gray zone where either ALT is high or liver enzymes are low or liver enzymes are high of the cutoff but viral loads are low. That is the area. But nowadays our hepatologist friends are more liberal. They are considering the treatment more promptly and more liberal way. They are now even considering the diabetes patient who have a hepatitis B, they start the treatment from the very early. They would not wait for the guidelines to comply. Your comments, Dr. Pratik?
Sir, that is a very controversial issue because then patients can come back to us and with all the legal issues and everything, guidelines are still not mentioning diabetic patients to be taken this therapy. But of course, we can discuss with the patient. Always you can ask for patients who are affordable, you can always give them the option.
Thank you, Dr. Poddar. Thanks for a wonderful presentation. And I would finish the felicitations session. I would request Dr. Subhash Chandra to felicitate Dr. Pratik Poddar. Dr. Subhash Chandra Tiwari. Thank you, sir. A round of applause, please.